will start recording it. Thank you, Tirza. Brilliant. Yeah, welcome at the Lunch and Learn. I will directly share a screen with you with a small presentation on it about the Institute for a Circular Society within the EWUU Alliance to give you a bit more of context surrounding this Lunch and Learn. So lovely to see all the people dropping in. So that's perfect. I will share a presentation with you first, and as an introduction, and then we will move on to the two presentations and content of the Lunch and Learn. Mm-hmm. Pick up in sharing the screen. Yeah, perfect. There it is. If all is correct, you can now see my screen. If it's not correct, please give me a sign, and I will. Okay. Well, first of all, welcome again to this Lunch and Learn. It's the Lunch and Learn of the Circular Hospital theme. And I'll introduce myself. I'm Carina Neef. I'm the program manager of the Circular Hospital theme within the EWUU Institute for a Circular Society. The Alliance, so the EWUU Alliance, here you see the embedding of the Institute for a Circular Society. So the Alliance is an alliance between 4 institutes, so the UMC Utrecht, so the Medical Center, Utrecht University, Wageningen University in Research, and the Eindhoven University of Technology. And there are 4 main institutes, which are Institute for Preventive Health and Institute for a Circular Society. And you're now listening to the Lunch and Learn of Institute for a Circular Society. And there are 4 supporting and work groups, Artificial Intelligence, Living Technologies, Center for Unusual Collaborations, and the Education Group. Just to give you a bit more of a context. Well, within the Institute for a Circular Society, there's also multiple layers, multiple themes, circular regions and circular hospitals, and integrated is our digital solutions within them. So it's actually a cross theme. And I've highlighted the 3 main themes we have overarching. So food and water. So water is one of the themes we will show today as well, including end materials, so material use. So these are the topics we have in both circular regions and circular hospitals. This is our team. And I highlighted myself and Florijn because we are the ones hosting this Lunch and Learn for you. So Florijn is scientific coordinator of circular hospitals, and I'm the program manager, like I said before. And it's good to see multiple team members present here as well. So some of them familiar faces, probably. Well, today's program, because we have a tight schedule, I love to give the floor, I hand the floor over to Guus in a minute from now. There's 2 of our projects, so seed projects, that will show what they are doing. So we'll highlight some of their research work. The first to start with is awareness of water care, which is supported by a social design studio. The ones presenting are Guus Kroijmans. He's a nurse at the nephrology department, so for the kidney dialysis, and Joes Janmaat, and she's co-founder of a social design studio called Studio Sociaal Centraal. And the second presentation is from Milota and Ryvann Soerohardjo. Yeah, thank you. And very special welcome also. Ryvann is from Paramaribo, so we'll join in from Suriname. about the life cycle assessment and knowledge sharing around the childbirth procedure in both the Netherlands and Suriname, so a comparison study. And I would love to hand the floor over now to Guus, and he will tell you more about the first presentation. I will stop sharing my screen now so I can hand it to Guus. There we go. Yeah, Guus, please feel welcome to take over.
Yeah, thank you, Carina, for your introduction. I will share my screen and start as soon as possible.
Maybe it's good to mention questions that you post them in the chat, and I will wrap them up at the end of the presentation of Guus. So, and then the questions will be answered.
Here we go. I hope this is it. Well, as you, Carina mentioned, I'm a nurse by profession, so I'm not a scientist myself, but I'm a bit of a workhorse within the Kidney Care project, which is a EU-funded project that aims to revolutionize kidney care for a sustainable and carbon-neutral health future. And within dialysis or kidney care, we've highlighted 4 sustainability hotspots, which I will explain later. So this is me with Professor Karin Gerritsen, who is not available today, but as I mentioned, I'm the workhorse and she's the brains. And we're portrayed here with a dialysis machine, which, as you can see, is quite big, as is the ecological burden of dialysis altogether, which I'm going to look into. When people have to start with dialysis, this is an end-stage kidney disease, which means that dialysis is only an option when kidneys fail altogether. Normally this happens when the kidney function is reduced to, say, 7 or 8%. And the problem with that is that kidney failure isn't registered by the patient themselves. Symptoms just occur when kidney failure is present, like 10% or 15%. So in this way, kidney care is a silent killer. So prevention in primary healthcare is key and is the most sustainable solution if we're talking about kidney care. So prevention is part of the Kidney Care project as well, because this is the most sustainable solution. Well, the 4 hotspots that I talked about are water use, energy use, the production of biohazardous waste, and transport. And we will highlight water for you, of course. Just to give you some insight, the annual carbon impact of our hemodialysis per hemodialysis patient. If healthcare was a country, it would be the 5th most polluting country in the world. So, and if we zoom into a dialysis patient, the carbon footprint of a dialysis patient is 18 times higher than an average patient. And this is because of water, electricity, waste, and transport. A dialysis session is not just one treatment, but it means the patient has to do 3 treatments per week for 4 hours for the rest of his life. Or if there's a transplant, of course, a transplantation is possible, but otherwise it's an end-stage renal disease. So this is 3 times a week for 4 hours. To give you an equivalent of this ecological burden, you can see you can travel around the world with this carbon waste. This is to give an example of the volume of water used in one dialysis treatment. And this is 156 times a year per patient. So there's a lot to gain, but first of all, I have to explain what we use the water for. To be able to do a dialysis and clean the blood of the patient, we have to upgrade the tap water, which is really clean in the Netherlands, but we have to upgrade it to our ultra pure quality. And for this, we use a reverse osmosis unit as depicted. On the bottom of this screen, you can see the normal water route. From the left, the tap water, which is filtered and then decalcificated, traveling to the reverse osmosis unit, as you saw just yet. And normally, all the reject water will go to the sewage. After reverse osmosis, just 1/3 of the volume is of the quality to be used in dialysis. And the dialysis machine makes it into a dialysate, which is an isotonic fluid with which we can filter the blood. And the dialysis machine as well has a wastewater stream, which normally goes to the sewage. The first intervention that we are looking at is to re-inject the rejection water back into the reverse osmosis unit. But in the end, there will be some rejection water that will have value because it's very clean still. So we are aiming to use this for cleaning, washing, or toilet flushing. And in the new build of the dialysis ward, say in 2 to 4 years, we implemented and have approval to implement toilet flushing with this rejection water. The waste stream from the dialysis machine itself contains not only toxic residue from the patient, but for the patient it's toxic, but it's valuable nutrients like phosphorus and nitrogen are in there, so they can be used, really good use for agriculture. Let's have a look. Agriculture purpose. Of course, there's some risk in the remaining of medication, but removal of medication residues is relatively easy with an alternating current. So there's been a study in Morocco where the wastewater of a dialysis machine is used for agricultural purposes, and the water is even cleaner than the surface water that they used before. And the last thing that we're looking into at our ward is to adjust the dialysate flow. Of course, you can improve the prescription of the patient to have a most effective dialysis with the least amount of water. Then there are some innovation pilots. We're looking into a monitoring device which should work alongside our reverse osmosis unit to provide us with online data about the water production, to optimize our operation and to be able to adjust directly so that we use less water.
Joes, I need to give you a heads up for 1 minute.
Yeah, I'm gonna go there.
Okay,
other pilots
thanks.
is to try to minimize the dialysis machine altogether, and this is done in Next Kidney, where there's a wearable dialysis machine which fits in a big rucksack and doesn't use tap water but uses 5 liters of fluid. So there's a big gain there, not just in water use, but for the patients as well, because they can travel and they can use their dialysis everywhere. To be able to do that, we need not just the diffusion in the filter, but we need some extra absorption. In the premier picture you saw on the left is the dialyzer. That's the filter that we use traditionally. And on the right-hand side, you can see the absorption membrane. But we want to do this in a mixed matrix membrane so that there's less volume for the patient to carry around. So our aim is to reduce the use of resources by analyzing procurement cradle to grave, and to come up with a 4-factor LCA database like social, economical, environmental, and patient outcomes, of course. We want to provide practical guidelines for healthcare takers, benchmarking tools to provide to the hospitals, a package of workflow optimizations which they can implement themselves, training modules and innovation of sustainable healthcare in dialysis. And all this is to ensure a future with water for all. I give the mic to Joes.
Thank you, Guus.
Yeah, thank you. Should we have intermediate questions or at the end, Joes? What is more, maybe it's better now, I think, right?
Yeah.
Just to see, are there any questions in the group? Maybe by raising hand or posting them in the chat. No questions so far. I do have a question for you, Guus, because I see multiple ways of saving or caring for water and saving water on the dialysis. Where do you think the most innovative power is? Where's the highest impact to be found on the measures we can take?
I think in the end it's in procurement, because there's a lot of travel for procurement and a lot of plastic waste in dialysis. For instance, we're looking into reuse of dialyzers, the filters that you saw on the left-hand side of the picture. Nowadays we do them single use, but there is a way to reuse them like 40 times, and on the same patient, of course, but and clean in between. But this would reduce the carbon impact enormously. So this is, I think it's in procurement, most of it.
Okay, perfect. I saw 2 questions coming in. And the first of one is from Rosalinde. Can you explain the LCA database?
Yes, I think I can. We do an LCA from cradle to grave, so we pick all the procurement of a dialysis and all the energy consumption, and we look into them with. We pick them apart, and all the detailed materials are put in the LCA database. So to be able to, vergelijken. To compare the different materials, different suppliers, and of course the different ways of doing a dialysis, because it's not only hemodialysis, but you can do a peritoneal dialysis as well. And of course there's a transplantation. So everything we want to compare to be able to advise our patients and to look for the most sustainable way of a dialysis. Is this answering your question?
I think it should be. Looking at the time, I think.
Okay.
If there's
okay.
Any
and the next question
questions, then I'll also put my email in the chat. That if there's leftover questions, then we can get back to you via email. Then I'll pick them up from there.
Yeah. Okay. The second question is about clinical tests, pilots. Yes, they are done. The innovations that I mentioned, these are clinical tests that are actually running at the moment. Like Next Kidney, and there are some trials as well on implantable kidneys with stem cell research. So yes, there are tests and pilots being done in the Netherlands.
Thank you, Guus.
You're welcome.
It's good challenging to keep it as compact as you did. Well done.
Okay, thank you.
Joes, I hand the floor over to you now.
Thank you. So I'm a social designer. I don't know if people know what it is, so I will explain it quickly. We use creativity in societal complex issues to see if we can come up with new perspectives. So that's what we also did in this project and still doing. Guus, can you share your screen? Because then we can see the pictures with the examples what we did. We
Yes, I
like
will
to
see.
try things out in the real world. We work physically. We learn by doing and we experiment. And what we did here is we focused on, is it radical or logical for a hospital to take care of water? So we went out there with different perspectives on that. For example, can we treat water from certain values? How do we treat water then? We made a meditation to connect with water. Please, the next slide, Guus. And we made an
Why is it
installation.
not working? I don't know.
Well, we made an installation which was part of an exposition with other artwork, and we introduced there the word water care. This was part of a dictionary made by a water research institute in the Netherlands. And they proposed new words for a new relation with water. So we introduced the word water care in the healthcare system, and we made a thought experiment for this to try the new perspective out. And I would like to invite you to is it still
Sorry,
working?
I'm trying to share again, but it's not working.
It's okay. Then we continue to the experiment. It takes 5 minutes. You're just guided by my voice, and let's see how this works. So I will share this short contemplation invites you into water care. Each day, you offer care with water, washing, cooling, cleaning, healing. But what if, while you care with water, you also cared for it? What if water itself, so present in a lot of acts of care, also needed your care in return? Take a slow, easy breath in. And let it go. Allow yourself to arrive. There's nothing you need to fix or do. Simply notice your breath. In and out. Let the body soften a little more with each exhale. And close your eyes if that feels comfortable. You are here. Imagine you are no longer human. You become water. Clear, light, alive. You begin as rain, falling gently from the sky, touching leaves, roofs, skin, and soil. You soak into the earth, held by the ground. There you are gathered and purified, drawn into dark, winding pipes, moving quietly beneath the surface. Until you arrive at a hospital. Sense what's around you. What do you see? What do you hear? What do you feel? White walls, warm hands, caring eyes, cool metal, flowing tubes. You wash hands and bodies. You cool you warm, you cleanse, rinse, and move on. You save lives. You are essential. You are everywhere in the hospital, yet rarely noticed. You are often unseen, used without thought, sometimes wasted, sometimes polluted. And still you keep giving droplet of water. You keep caring. To keep giving, you too need care. You are important, droplet of water. How would you like people to care for you? How could I keep you clear and alive? How could I treat you with gentleness and respect? Let these questions move through you, softly, like waves. Now, bring your awareness back to your body. From water, you return to being human. Feel the ground beneath you. Move your fingers, your toes. Take a deep breath in. And slowly let it go. When you're ready, open your eyes. You are back. How do you care for water? So, I would suggest let this question flow into you the rest of the day, and we move on to the next presentation. I think, Carina.
Yeah, perfect. I would like to hand the floor over to Megan. I don't know, Megan, if you're back. If you're back again from the exercise.
Yes.
Maybe you would like to introduce yourself to all that are present here.
Yes, I'm going to go ahead and start to
proceed
share.
quickly.
Yeah, share my slides. Can everybody hear me okay? All right. We want to get to showing you one of our products, a couple of the products that we developed. So we might go through some of our slides a bit quickly. Ryvann is here with me. Ryvann, is your microphone working?
Hi, yes, my microphone is working. Can you all hear me well?
Yeah, and see you now.
Alright.
Thank you. Lovely that you're here.
So just to give a little image of Ryvann and myself working in the field, not only capturing our data, collecting data, but also working on an ethnographic film, which we'll show you a short teaser of in just a few minutes. But today we want to tell you a little bit about what we were doing in our project, what our aims were, who's part of our team, the methods we used, some of our findings, and we'll try to go through that pretty quickly, I think, because we want to show you mainly why we needed to use various data sources or data collection methods to get the findings that we have, and where we'd like to move next. So Ryvann, would you like to tell us a little bit about the project?
Yes. Hi. My name is Ryvann Soerohardjo. Actually, a little background. I'm from Paramaribo, Suriname. Here now in Paramaribo, Suriname. I know Megan through our many research projects that we've done. So I'm a junior researcher, and I'm also in my last weeks of studying medicine. And this is actually the first project of this kind that I did. And it's called the Shining a Light on Materials Used. And we try to do this critical life cycle assessment and knowledge sharing on childbirth in Suriname and in the Netherlands. So the core of this project is to not only gather data for an LCA, but to prove a point that that awareness and that the data is not sufficient enough to get the whole picture. And we try to capture it with an ethnographic documentary. And the goal of this is to show not only healthcare professionals, but everyone that the way we do things can differ from one another in other settings. And this encouraged bidirectional learning in a low middle income setting and a high income setting. But it also creates awareness of how we as healthcare workers and anyone in the healthcare system can contribute to a safer planet, as we should say. So I think maybe we can get some slides up if
Oh,
that's
oh
okay.
no, I thought I was sharing my slides with you. I'm so sorry. I've been like sliding through the
Yes.
slides and being like, hey, wow, that's great. Sorry, everyone. Very silly of me. Now you have the slides.
Yes, so
There we go. I was already here.
yes, so we had three aims: is to do a replicable plan for knowledge co-production and sharing about circular practices. This is to encourage the bidirectional learning in a high income and a low income setting, and to also make an ethnographic film to show that data is not only sufficient enough to make conclusions, but having a film also creates awareness in this project. And hereby we collect not only quantitative data but also qualitative evidence to support best practices regarding the circulatory material used. Um, so the team consists of an advisory panel from the Wilhelmina Kinderziekenhuis, that's Tobias, Evelyn, Kitty Blumenkamp, and Sasha Tansen. And from the UMC Utrecht team, that was Megan, Joyce, Alai, Arte, Noah, Kolpa, and George and Juliet. We also had Sinyu from WUR, and from the Anton University, so here in Suriname, and Academic Hospital, you had me, Ryvann, and Lashmi Kolan. She's the epidemiologist and also a gynecologist here in Paramaribo. So we try to continue research here in Suriname, but also do new projects. And life cycle analysis is actually unknown here in Suriname, and actually not many people have heard of it. So when we started the project here, it was also it was also a campaign to create awareness about why a life cycle analysis is important, and also a challenge to gather data, because not everyone knows what a life cycle analysis is and why it is important.
So what we decided to do, I'll take it over just real quick if you don't mind. Thank you for that. So like Ryvann said, we were doing qualitative and quantitative methods of collection. And what we decided to do was that I would go to Paramaribo for 6 weeks and collect the data at the sites there, vaginal births and cesarean sections. And that Ryvann would then come here and complete the same protocol. So he then spent the same amount of time here, and that we took turns filming at the sites where we were at. So what we've created is not only a data set that's collected by both of our partners, so the UMCU and the AZP, but also an artifact, a film ethnography, that is also viewed through both of our eyes, so that both of us as filmmakers have been looking at the practices that we see. Ryvann, I'm going to go ahead and say that maybe we should jump through pretty quick, just because I'm looking at the time and it looks like we have 10 minutes left. We can tell you a lot about the choices we made for functional units in the LCA. I don't know how much knowledge there is about LCAs here and how much detail I need to go into, but just because of the time we had, we made certain decisions about what we did and did not include. We decided to look at the moment from partus to birth for the cesarean sections and the vaginal births. And this is what our data sets look like. Ryvann, do you want to add anything about what it was like for you to collect this, or what your insights were?
Yes, so the things that we actually encountered in the practice is that in a low-income setting here in Suriname, it was way more difficult to gather an LCA data, because most of the time we just don't know where the materials are from and how old they are and how many times they have been used. Many of them are from donations, and some materials are reused. So, for example, a cocker clamp that is broken is being reassembled and reused for another medical tool. So that was quite a challenge to actually gather specific data of where it comes from and where the manufacturer is from. But I think it creates the beauty of this project, that there are differences in a high and low income setting.
Yeah. So if you look at our data collection here, it looks like certain hotspots are coming out. We realized, because of what Ryvann just said, that it doesn't work at a product level to do an LCA comparatively like we were trying to do, simply because of the procurement reasons that Ryvann just mentioned. A lot of times you don't know the brand of the product, you don't know how often it's been used. So trying to take what we know from other LCAs about usage at the material level gave us better data. And also looking at the day-to-day practices. These are a couple stills from filming, so you can see just various differences with your bare eye in how materials are used, packaged, what kind of materials are being used or reused or thrown away in single use. So that would be Suriname versus the Wilhelmina Children's Hospital. Also differences in how materials are made on site and sterilized versus materials that are bought, purchased. Also just the size of the amount of storage facilities and how much materials are present to be used is not something you can capture in an LCA. Ryvann, do you want to tell anything about the hotspots?
Yeah, so I'll keep it short. In the academic hospital, through the LCA data alone, we could conclude that it's mostly a product-centric emissions, and due to the single large surgical kit that they use during the cesarean sections. In comparison with the UMCE, it's more a supply chain centric emission. There we deal more with upstream energy and use in manufacture of disposable plastic items. But if we compare it with the ethnographic data, we might have another view on this, because, for example, the single large surgical kit that's being used in the academic hospital has almost no disposable plastic items. Almost all of the items are being used for many, many, many years. So that is actually something that you cannot really put in an LCA and gather the data from.
Exactly. So we want to, in the tiny amount of time we have left, like we said, we made a teaser for you. Is this okay, Karina, if we show the video, or do you think we're running out of time?
I think it's okay to show the video. I don't know how long will it take.
It's 3 minutes. So then we'll probably have to not share a lot of our findings and next steps, but we'd like to give you just an image of what an ethnographic film can do in terms of adding to the information from an LCA. So here again, a few stills.
That's very interesting.
Great. Okay, so we'll show that. Keep in mind, this is a very rough cut. We just tried to take a few fragments to show to you, just so you can get an idea of what a film ethnography looks like. It's not your standard documentary. We don't use audio, sound or music. We use only what the people have said and what's going on in day-to-day practice, just as a sort of like a these are all images from stills that we still have to edit. But here is a very short version of the teaser that we'd like to present to you.
I don't hear the sound now, Megan.
Really? Okay, because I have the sound here with me. None of you have sound. Okay. What if I stop sharing and then I'll present maybe via this route? I'll try it in a different way. Ach, zeg. All right, let's try it one more time. I hope that this works.
When you share your screen in Teams, you have to click that you allow the sound to be shared as well. It's a separate toggle in the share screen within Teams.
It's funny because it worked when we were just trying to do this. So
Yeah, we practiced it. But
yeah. Okay.
But sometimes external users, then it gets a mess.
All right. Well, I go ahead and mess with this. Ryvann, do you want to say a few of the next steps? I'll try to look around here where I can find that. Maybe I'll try this. Such a pity for all of you. Can you hear me now in a broad microphone? Okay, maybe this might help if I take this out and hope that this will do it.
I practiced this with Joes as well with the sound, and when she took off the headphones, it also helped. So
okay,
that might be maybe that's the trick.
Maybe this is the lucky bit here. Now it's gonna work. Okay, third try's a charm, right? Okay. Now I don't have any sound. Do you have sound? Okay.
It has subtitles though, so.
It has subtitles. Yeah, it's a pity. What we could also do is share with you the link if anybody's interested, that we could share the link with you. Just keeping in mind that we only have 2 minutes left. Pity for us, pity for you, but alas and alack, sometimes these things work like this. Maybe we can talk a little bit in the last 2 minutes about what we would like to do moving forward. I'll go ahead and try to share my slides very quickly with you without pity the slides. Ugh. Okay, can you see now?
Yes.
All right. Ryvann, would you like to say what you think our next direction should be with this? Oh, could be that we lost Ryvann.
No, you guys can hear me. Yeah.
Okay.
So our next step includes like finishing the validating and ethnographic film with the stakeholders. We will run screen sessions, and now we will reevaluate the LCA dataset. It's a small sample, so it takes a little bit more time to reevaluate the LCA dataset with expert support and finalizing the manuscript. So this way we can share our findings with all the groups. Yes.
Yeah. I imagine there's a lot of questions, and again, it's such a pity that the sound didn't want to work in the second part of this, but in the 30 seconds we have left, is there anybody who'd like to pick our brains about what we're doing?
There's one question in the chat already from Huub.
Mm-hmm.
Is that beyond the LCA, are there already any ideas for mitigating strategies to reduce the materials and greenhouse gas footprints?
Yes, in fact, we'll be talking with the Groene OK, the active advocacy group here at the UMC about that, what we can do to reduce emissions here, at least. That involves maybe looking at how we're packaging our reusable OK sets, maybe using cloth instead of paper, which is the best practice in Suriname, and trying to look at some other images that we've gathered from both sites to figure out how to move forward and what we could do easily. I think in Suriname, I'm thinking about perhaps procuring more sterile OK jackets so that there's enough present and available. Maybe thinking otherwise about catheters and other kinds of systems that can be used and maybe purchased and prioritized so that helps with those operations and procedures.
I don't see any questions anymore until now in the chat. I posted my email address in the chat. So if any of these if questions will pop up, please know where to find me, and I'll make sure I'll distribute them to any one of the 4 lovely presenters of the day. So yeah, thank you. I think we should close. I see people leaving as well because there's other arrangements for this day. So the ones who are and were here, thank you all, and thank you especially Megan, Ryvann, Joes, and Guus. Thank you for your lovely presentations, and yeah, we look forward to the next steps. Thank you. Hope to see you all in the next one.